Hello and greetings from Atlanta. Thank you for the opportunity to participate in CVI, and I have the pleasure of presenting on common femoral endovascular intervention, some technical considerations for complex endovascular therapy for the CFA. I'm Dr. Drew Klein. I'm one of the interventional cardiologists and vascular and endovascular specialists here at Piedmont, Atlanta, and thank you very, very much for the opportunity to present. I have no conflicts of interest to share. I want to start off by talking about endovascular intervention, about a little bit about classifications, because I think when we talk about CFA intervention, you really need to look at it almost like a left main LAD circumflex intervention in terms of which vessels are being looked at, which vessels are the occlusions, or is it something that's heavily calcified, is it something that's involving the profunda, etc. And so the one classification that went out there was type 1, type 2, or type 3 lesions, or type D involving a graft. And so I think it's important when you're looking at this because obviously type C lesions in this classification are different than type B lesions. And this is just one classification that's out there. There is another classification, which I call the interventional cardiologist classification. That's Medina classification, and that's using the same exact presentation or classification scheme that we see in the coronary. So Medina 111 involving the PFA, the superficial, and the common femoral. That would be the most complex. And I think it's important when you're looking at this because we know from the cardiology literature that the more complex you're getting into, more chance that you may have to use bifurcation stenting, which is not the ideal type of stenting strategy in this vessel. Specifically, try to avoid stenting in the profunda if possible. I think it's also very important when you're talking about common femoral intervention that really the etiology of the common femoral disease really impacts the outcome. If it's atherosclerotic and it's more calcified, you can do pretty well with acute success, but worse long-term patency. And that's different than if you're dealing with non-atherosclerotic disease, such as post-procedure thrombotic occlusions, either from a vascular closure device or from manual compression. These do very well acutely and do very well long-term because usually these vessels are normal. And that's in contrast to the atherosclerotic disease, which is usually not just limited to the common femoral. If you look at Bonvini's data, looking at predictors of adverse events across the board here, it's really procedural failures if it's involving the bifurcation, if stents had to be used. Again, as we've evolved, if it's after 2001, patients did better than if before 2001. A lot of this has to do with some technology, which we'll talk about. Restenosis rates, again, going up depending upon the complexity, as well as if you had to do both the common femoral and infrainguinal disease. It also depends on who you're working with. If you're looking at Claudicants versus critical limb ischemia, obviously CLI patients, really you're dealing with a tougher group of patients. These patients are more apt to get stented. They're often, the idea here is that Claudicants, we try to avoid stenting, but CLI patients, they have such poor outcomes overall. We really want to try to perfuse that limb as best as we can and optimize inflow to the wound. So those patients often get stents. Those patients with diabetes in Rutherford class 4, 5, and 6, they do worse versus Claudicants. And really, often, just like in any vascular intervention, you really need good outflow. You need good outflow of the SFA and popliteal. I think that's been shown as well. Big issues, again, shown in a different group. Same author is looking at TLRs. Again, if you have Claudicants with borderline into class 4, diabetes, kidney failure, stent use, these are all predictors. And so some technical considerations, and I'll just bring up my first case that I ever did, my first CFA case as an attending. This was just a few months after leaving fellowship. This is a patient who presented to me who had Rutherford class 3 claudication. I had a focal common femoral stenosis as well as SFA popliteal disease. So in my opinion, had heavily calcified disease. I referred the patient to vascular surgery at this time, not only because he had common femoral disease, but he had this occlusion in this popliteal in the P1 into the P2 segment. I should do well with a FEM below the knee bypass. Unfortunately, the patient developed cancer sometime after my referral, colon cancer. He was turned down for surgery. He was lost to follow-up and then presented back to me now 9 months later with severe ulcerations, extreme pain, and surgery, again, had no desire to intervene upon him at this point, secondary to his cancer, but also due to his comorbidities. So this is what his angiogram looked like 9 months later, complete occlusion in the SFA, or CFA, with complete occlusion in the SFA as well. But good collateral flow, filling both the SFA and the popliteal, so we could see where we're going. So we were able to cross through true luminally here. We used a quick cross 0.035 with stiff angle glide wire and then a choice floppy wire to select the SFA. Got a catheter down the SFA. We actually did directional atherectomy at that time to debulk that common femoral lesion that we knew was present 9 months ago. And this is what the vessel looked like after atherectomy alone. This was a very nice response with just atherectomy alone. And then after balloon angioplasty of common femoral using a 6 by 60 millimeter balloon, which was a little bit on the undersizing in retrospect, but now, again, this is my first case, did quite well with this common femoral intervention. In fact, a patient did have complete relief of his leg pain. Second case was a 7-year-old gentleman who had CAD, sepsis bypass, severe left lower extremity claudication. He had an absent left CFA pulse. He had failed 3 months of Pletol and absolutely refused surgery. His biphasic, his ABI showed monophasic waveform on the left with an ABI of 0.47 with a toe pressure of 50. We got a preoperative heavy calcification noted on a CT angiogram, all involving his common femoral. Doesn't look like he had much of a lumen there. But what we could see was that it was heavily calcified. We knew this was going to be a challenge. Again, I broached the subject about doing surgery. He did not want to pursue the surgery, did not want to see anyone from surgery for various reasons. So we took him to the cardiac catheterization lab. This was his baseline angiogram showing complete occlusion of his common femoral with collateral filling of his SFA and profunda. This was worst case scenario here with heavy calcification. Again, going on the idea that we really needed to cross true lumen and true lumen, we went with an 014 system, looking for a micro channel in hopes that we could cross true lumen and true lumen. We were able to cross through with the Pilot 200, then use the stiff angle glide wire. Once getting about halfway through, we were able to switch out and then cross the last portion with a stiff angle glide wire 035 system and enter into the true lumen. We then, as you can see here, dilated using a 3 millimeter balloon, showing that we're again true lumen here into the SFA, then entered into the profunda using a different wire, confirmed that with injection of contrast. Then we put double embolic protection device here. So my idea here was to debulk this very heavy calcific disease. However, I did not want to shower any emboli into the profunda. I did not want to shower any emboli into the SFA. So I thought prevention here would be critical, but we also did not want to cut the wires. So this required an 8 French sheath with crossover. We were able to do directional atherectomy to the SFA, to the common femoral. Again, in this case, we were able to go on the profunda wire, really directing the cutting blade away from the other wire, really showing where we were going and could direct the atherectomy in this way. After using balloon angioplasty alone, there was a slight dissection, but again, this was non-flow limiting, but a good response with this, and the patient actually did quite well on follow-up. This is our final angiogram showing good flow all the way down. His common femoral velocities were 127 to 241. Patient did quite well long-term as well, despite it being a completely occluded and heavily calcific lesion. However, this is why I always use protection for embolic protection. You have to do it with atherectomy. You can see both of these baskets, both in the profunda and the SFA, had debris. So I think if you're going to use atherectomy, especially directional atherectomy, you should absolutely use embolic protection. The third case, looking at technical aspects of common femoral and endovascular intervention, it's a 72-year-old patient who presented with a non-healing wound, class 5. With heavy calcification, right SFA was occluded with right CFA, high-grade stenosis. This was a very challenging case. It was performed by antegrade and retrograde. We crossed the lesion with reverse cart coming up from below and above, and had to use some very small coronary balloons because initially we couldn't cross at all. This is an example of some of the calcification that we're dealing with here. This is down in the SFA. You can actually see how we're spiraling with the dissection, heavy calcification throughout. You can see how we're doing reverse cart here with small 1.5 millimeter balloons, and how crazy the calcification was up here in this common femoral. This was indeed a rock pile. This was recent here at Piedmont Atlanta. I had the availability of shockwave peripheral vascular intralithotripsy system, and this is the common femoral that we treated with using this system. And I think what you'll notice here is that this involving the CFA, there was a marked underexpansion, but then after a balloon angioplasty, we showed a great response with balloon angioplasty alone. We actually wound up treating the whole SFA with shockwave and a superior stent, and you can see the final result throughout the SFA. And we didn't actually have to stent the common femoral at all. That was able to be performed with shockwave with balloon angioplasty alone. And that is my preferred treatment nowadays in 2020 with heavy calcific disease, is to use lithoplasty if we can. Here's another case that I call lollipop. This was a common femoral case, how I turned a lollipop into an all-day sucker. This is a 62-year-old gentleman who showed up after a cath. 2 weeks later, wherein an angioseal was performed. He showed up actually 2 days later with right leg pain, exertion, just basically ecchymosis, didn't feel great. He wound up coming up to our hospital, being referred. This is our baseline angiogram showing complete occlusion in the SFA. Remember, I showed you etiology predicts outcome, and this is an acute occlusion, should do well with endovascular therapy. This is the baseline angiogram up close to the right CFA, large amounts of thrombus. We were across through there using an O35 system without any issues. We entered into the profunda. We navigated then into the SFA. It was thought initially that this fine, we'll just treat this patient with a balloon angioplasty, maybe cut out the dissection flap that's usually present. However, you can see large amounts of debris here in the common femoral all throughout, with high chance that this was going to embolize. I fell for this, and nowadays I would actually treat this patient with probably catheter-directed therapy. Back then I thought, oh, we need to cut the dissection flap out, balloon it, and see how the patient does. We were able to, again, this is a runoff angiography showing great profunda, great SFA. So this is really just a quote-unquote normal vessel that got messed up by the angioseal. So I made a couple mistakes here, and I think this is where the advantage of living from somebody else's mistakes. Number one, I put a 7 French into an 8 French. I should have put an 8 French right off the bat and put embolic protection down both vessels if we were going to do profunda, if we were going to do directional atherectomy. I had to pull the profunda EPD to do rheolytic thrombectomy. Again, in 2020, I would have done catheter-directed therapy with ECOS or with any infusion. I wasn't patient back when I did this several years ago. I also wasn't as familiar with TPA. I think now with my experience with pulmonary embolism, I'm much more comfortable administering TPA directly to the vessel. Obviously, in these cases, in patients that have had recent punctures, you need to be careful about that because patients can start bleeding from their original puncture site. And I've also seen that happen here with rheolytic thrombectomy as well. So if you're bringing a patient back and you're giving TPA pulse dose thrombolytics, you can actually open up the original arteriotomy. Now you got bleeding and clotting, which can be quite nasty. This is after a passive DVX angiojet on thrombectomy mode. You can see here I've lost now the profunda after having pulled the EPD from the side. Major problems at this point. I tried going down and lassoing the thrombus using an EPD. Clearly, I'm not a cowboy. I could not lasso well. I was able to go down there and basically do balloon angioplasty and restore flow to the profunda at low pressure. After pulse spray thrombolysis, you can see there's still a bit of pulse spray into the profunda, that is, there's still a large thrombus there. We then used low pressure balloon angioplasty using 5 millimeter balloon. Basically fragmented it, pushed it up against the side, restored flow down to the profunda, then treated the common femoral. At this time, it was my thought process the patient had a dissection there from the angioseal, and therefore we cut this out and perform atherectomy because this is often what happens. the foot plate from the angioceal goes up and dissects the common femoral, leading to thrombosis. That's what it looked like after atherectomy, and then Evercross balloon angioplasty using an 8mm balloon. This was our final angiogram after removal of the spider. Pretty good runoff all the way down. Look what I found. Not only did I find a bunch of thrombus in there, but we actually found the foot plate to the angioceal as well. So that had been embedded in some tissue as well. I think again here, SFA spider saved the day for distal embolization. This was the thrombus that was captured in there. Always use protection. I think it's critical anytime you're going to use any sort of atherectomy, but especially in these cases with acute thrombus. Again, I brought this case up to my former program director, Dr. Messenger here, and he said, seems like you managed to turn a lollipop into an all-day sucker, and sure enough, I did. It took me about 5.5, 6 hours. In 2020, what I would do is I'd actually go to catheter-directed lysis, I'd give some lytics, and then bring them back 24 to 48 hours and then relook. And that's what I would do today. Would have sped up the case, would have probably resulted in a better outcome, but the patient did pretty well long-term with no issues long-term. So CFA disease, I think you have to choose wisely. Some technical considerations are this is not something you should be doing in your first couple years out. You really have to be true lumen. You never want to compromise the profunda. Really, you want to maximize the luminal gain, and that's where intravascular ultrasound can come through. Remember, calcium inhibits luminal gain. So atherectomy, there's no data, but something you could consider, either directional or orbital. Cutting or scoring balloons, there's no data for this. Lithotripsy, there's no data for this. DCB, there's no data for this. And one thing I would bring up, if you're going to use DCBs, make sure you document discussions, risks, benefits in today's world with the FDA warning. So that being said, I think it's important that to understand that calcium, common femoral arterial disease can be treated endovascularly. I think the outcomes have been shown by other presenters showing that indeed it does well with endovascular therapy, but not something you want to choose right off the bat. And you really, if you're going to do chronic total occlusions, this have to be true lumen. With that, I'll thank you very much for the opportunity to present here for CBI. Thank you.